to tell you a little bit about my background, which wasn't covered. It's pretty broad. I have experience as a NIMH researcher. I'm former chair of the mental health section of the American Public Health Association. That is a group of the top psychiatric epidemiologists and mental health service researchers in the United States. I also am a family member. I was guardian of a sibling with paranoid schizophrenia for about 10 years. And I've been in clinical practice for quite a while. And prior to being in private practice, I worked primarily with people with very serious mental illness in the public sector. And I'm a former attending from a mental health rehab facility at San Francisco General Hospital here in San Francisco. So that's just a little bit of background. You can see what my presentation is. Let's go to the next slide. The most important thing about mental disabilities is that people recover, and that the most important thing about how we approach any kind of services, whether they be clinical or vocational, is that we keep in mind that, one, recovery is possible, and that the most important thing about services being effective is whether or not we approach services in a way that promotes what we know about how recovery is accomplished. And this is just one definition. This comes out of a Substance Abuse and Mental Health Services Administration task force that was convened with providers, consumers, researchers, government agencies, to come up with a definition that would help define what is the driving concept of mental health recovery in the United States, and probably internationally as well. Next slide. Now, these are the fundamental components of recovery that they came up with. They're pretty consistent across other studies and surveys and evaluations, and I'm just going to kind of review what these are. Self-directed really means that clients direct their own treatment and recovery. They define their goals, and that ultimately the services that are provided based on what they feel they need, and they're the ones who guide the focus of the treatment and also the particular array of services and needs that are part of their care plan. Individualized and person-centered is really a continuation of that concept, that every client has a different set of needs and services that will help them achieve recovery, and that the services are focused on them, not on the provider, not on the structure of the healthcare system, but on what the clients need and what their environment and their community means to them. Empowering. There are lots of definitions of empowering. It means that clients or consumers have the authority to choose from a range of options and to participate in all decisions. So choice and self-determination are two really key components. And that includes the allocation of resources, that they get to choose who they want to take care of them, what services they want, when they want them, and how they're going to be delivered. Holistic means different things, but it basically means that all domains of a person's life and all aspects of healthcare and services are part of the care plan and the recovery approach. That could be mind, body, spirit, community, all domains of people's lives, whether it's their family, their work, all different aspects. Nonlinear means that there is no linear continuum of care. People don't need one particular service at one particular time in a certain order. It has to be provided in the organic way that each person needs those services And it has to be adapted for their particular needs and preferences. Strengths-based is just that. We've heard that concept brought up before, is that you have to build on the strengths that a person has and empower them to use them, develop them, and that's part of the core of a recovery approach. Peer support reflects the fact that consumers have historically said they need communication, support, and services that are peer-based. And that's a consistent part of any array of programs and services that are going to be available, including vocational. One of the things that National Alliance for the Mentally Ill does is it trains peer counselors in certain sites. It's not available everywhere, but there's a peer counseling training program, and there are also some other peer counseling programs in some of the city colleges around the Bay Area as well that help train people, and not particularly, I don't believe, in vocational services, but is providing peer supports, consumer to consumer. Also, a lot of the drop-in programs that we see in San Francisco and around the counties really are staffed by consumers and involve peer contact, really at the initial contact when people come in to try to access services initially. Respect, I think that's pretty self-explanatory, that people be provided services in a way that promotes their dignity and gives them a sense of responsibility. That's the other piece of that. And hope, sometimes I think hope should be at the top of the list. Because in order for people to become engaged with a psychiatrist, I mean, who wants to go see a psychiatrist, right? We know about the stigma, and I think that, it shows a lot of courage, whether a person has a disability or not, to come and see a mental health provider in this society where there's so much stigma and there's also so much discrimination against people who do actually access mental health services, that I think it's really important for the provider to instill confidence and hope that they can help them, and they're going to focus on their needs and their preferences and trying to help them achieve recovery. There is a lot of research, and I basically pulled out the major mental health outcomes study that I believe is the best one that's been ever conducted in the United States and possibly the world. And this is the Ohio Longitudinal Consumer Outcomes Study. And this was conducted over a period of 5 years. And this was the only, and I'd say first, non-black box major outcomes research study in the United States on mental health outcomes in consumers. And what I mean by it wasn't black box is usually they said, here's the services we're getting and here are the outcomes. But they never really looked at, in a systematic way, who were the clients, what were the particular amount and type of services they received, and what were the particular specific outcomes that they achieved. Well, what do you think this showed? And this is consistent with every outcome study in the United States. It showed that, unfortunately, neither service, amount or type of services made a difference in client outcomes. It showed that the only thing that really mattered in achieving positive client outcomes was whether clients believed that their needs had been met. That was it. And what does that tell us? It tells us, I don't think it tells us that services don't work and don't matter. I think it tells us that the fundamental premise of somebody achieving recovery involves an environment in which their needs are getting addressed and they are in tune and aligned with the people that are trying to help them. And so that was very critical, and this is and the top need in this study, consistently listed by clients in terms of their unmet need, was vocational services. And this is pretty consistent around the nation as well. Not only is this probably a top need that's highlighted by consumers, but it's a top unmet need. Next slide. So supported employment is important because in the mental health research field, it's been shown to be, it's been developed and demonstrated as what we would call an evidence-based practice. Now, I don't think that the only services that work are services that have what are considered to be good evidence. I think that there are a lot of practices out in the community that people do that actually do work, and that the real gold standard of whether something works is that the outcomes that we achieve are good. But nevertheless, it helps to know that there are certain manualized and structured services that we know how to do, that if they're done close to or with good fidelity to the model that's been developed and studied, that will probably get good outcomes as well. And that's what supported employment tells us. It's a program that has been very well documented, the SAMHSA website, and this is Gary Bond, who, Robert Drake, who's at Dartmouth, is one of the people who has really developed and most studied supported employment. Gary Bond has a center in Boston, and this is one reference. But so it's an evidence-based practice because it's supported by both clinical trials and by effectiveness research, which is a little bit different. One's controlled and the other's a real-world type of research. And it's a well-defined approach to helping people with disabilities. This is particularly for people with psychiatric disabilities, but I really think that developmental disabilities and psych disabilities should come under a general category of mental disabilities, because there's so much overlap and a lot of the same problems. And disability will always be a question of degree and quality. And it was first introduced in the 80s. It has, as it's noted here, well-defined components and a fidelity scale, and it's implemented throughout the United States and the world. And I have a footnote on one of the next slides that has the SAMHSA website, which has an entire toolkit on how to implement it. So any providers or programs who want to know how to do it, they just go on the website and you print up the manual and it tells you everything on how to do it. So next. So these are core principles of supportive employment. I think one of the things that becomes very striking is that there's a lot of overlap between the core principles of recovery and the core principles of supportive employment. And if you look at the ways in which it gets implemented, these parallels are important. And there are also some additional implementation principles that become important in terms of how to implement these in practice, wherever that practice may be. So it's based on consumer choice. That also means that no one is excluded, and that anybody who wants to work gets services to help them try to work. It's integrated with treatment, and I'll talk a little bit more about how I do that in my adaptation to private practice, but it means that the clinical and the vocational services are integrated. Competitive employment is the goal. There used to be, when this research was starting, a question of whether you train someone first and then you put them into the workplace and see how they do. Well, it turned out that didn't work as well as just putting people in the workplace and supporting them in the job and helping them do it. Again, job search starts soon after a consumer expresses interest. That's part of work placement first, as soon as not training first. Train on the job. Follow-along supports are continuous. That's the whole idea of supported employment. It starts at the beginning when they express interest, and it goes throughout as long as they need those supports on the job. Those continue. and they continue hopefully along with integrated clinical services. And consumer preferences are important. I would say they're essential, and they guide the help and support that someone receives. So these are basics. I mean, they're you can look at the website for all of the details of this. I'm going to kind of move away from the toolkit to how I apply some of these things in private practice, because I think what's really important is that even if you can't implement a supported employment program where you are, you can find ways of doing a lot of things right in whatever kinds of vocational and clinical services you have in your community. The other thing this means for consumers is that consumers can ask their clinical providers to start providing some of these vocational services if they're services that are in fact not otherwise available to them. And there are lots of ways to do that, and that's one of the things I'm going to highlight, is that you do not have to have a formal vocational program to start implementing effective vocational services and supports for consumers and clients. So engagement, obviously, so that's not an issue for me because it comes up automatically in my private practice, and when people aren't referred to me for vocational services, it's just part of what we do in my practice. And so assessment, what I'm going to look at is how I do the assessment, the job finding and supports within the context of my practice. All right, so this is a little bit about the population of people I serve, who I work with in terms of vocational supports. It's a little more complicated, this, but I tried to come up with the two main categories that really would describe how I work with people with vocational supports. I have people who, and this came up a lot in conversations about what happens with people. They become disabled, mentally disabled, while working at the job. They're on the job. They may or may not have had a disability before. They may have never been diagnosed. And this came up with a question that Stephen raised to Anita, I think a little earlier, was what happens when somebody is on the job? How do you figure out if they're disabled or not? Well, disability has many definitions. It has a legal definition according to ADA. It has definitions according to state disability laws. It has many different definitions. But my job is to look and see if somebody's clinically disabled in terms of major impairments in job, family, or functioning, self-care. I look at to see, is this person functioning? Are they disabled? Can they do their job? Can they take care of themselves? Can they take care of their families? Can they function? So I'm looking at the most basic level, and I'm going to look at how I assess that and what I do with that information. And there are also a lot of different disability scales. There are lots of different criteria you can use, but ultimately, it's my job to figure out if somebody can, say, continue with their job or not, to help them figure out or not. So they may, and I want to make a note, I put in special accommodations instead of reasonable accommodations because I serve so many people who are in secondary education and colleges. I have so many student clients that I work with all of the universities and City College, Academy of Arts, San Francisco State, Mills, with all the disability programs there. So I've been working on a couple of student cases. So that's why I put in special accommodations, because I've been writing letters for the past few weeks for special accommodations. But it's in the employment setting, it's obviously reasonable accommodation as opposed to special. And they may want to remain at work or return to an existing job, or they may want to find an entirely new one. That's part of the process when someone begins to have problems functioning at work and it begins to affect their performance or jeopardizes their job. That's what you're trying to assess. And then the other population of people are who have been recently hospitalized or haven't worked for a long time and are really returning to the job market or job force after a really long time, or maybe have never really been, what's the word, really employed in any significant capacity. So I work with employment issues with people from 18 to 68. A really broad range, all different kinds, from corporate lawyers to bartenders. And they all have similar and different issues, and they get addressed. I also deal with, I have only a few people with diagnosis of schizophrenia in my practice now. I used to serve primarily people with schizophrenia and severe bipolar disorder. Ideally, I would be in a team of people. I mean, I'm doing a lot of things that I would not otherwise do if I had a team to work with to help me provide these services in a more efficient and comprehensive way. But I work with people with OCD problems, PTSD, adjustment disorders, bipolar, schizophrenia, major depression, eating disorders, everything. Next slide. All right, so this is some special considerations, and I wanted to add something to this that I think is really important. People who present in my practice, I used to see mostly people who are on SSI, and a small percentage on SSDI. Now, very few people I see are on SSI or SSDI. A small amount are, and a few on, and subsequently Medi-Cal and/or Medicare. The majority, though, has some sort of private insurance. I'd say 60%, but the rest have no insurance whatsoever. They have none. And also, if they've been employed for a year with one employer, they'll typically be covered for up to 6 months of short-term disability benefits under state law. Some employers also provide supplemental short-term or long-term disability policies. And some people carry individual disability insurance that may cover them if they're unable to work at all. And in some cases, the coverage will be if they're unable to work at their particular job. Say they're a therapist, a psychotherapist, that would be, and they can't work as a psychotherapist anymore, or so that's an example. I think there's a slide I'm missing that I wanted to, there's a special considerations, workplace and disability. Go back a second. There's a slide missing. Workplace stressors and disability. There it is. Okay. So I wanted to talk about this a little bit. Some clients develop a disability at work. Sometimes, as was noted earlier, because of other life stressors, they lose their house, they get a divorce or whatever. Sometimes the work environment in itself is toxic. It really varies. If, in fact, it may be that the work environment or working conditions have led to the person's disability, either causing it or exacerbating something that's pre-existing, I never encourage them to file a workers' comp claim. And there are lots of reasons for this, but the main reason is because the way the law has now been written, it's impossible to win. That's one of the main reasons. The second reason is because it creates enormous additional stressors for the person. I mean, the idea of trying to even think about getting special accommodations from somebody you're filing a suit against for having caused your disability. Talk about a difficult situation. How are you going to get cooperation from somebody who's being sued? I mean, it's pretty basic. And then it always interferes with treatment, because I have people come in, we have to fill, Dr. Cohen, I have another form for you to fill out. We have to write another letter. You know, we have 20 pages. This man came, I totally empathized with this man who spoke up this morning, because that's the reality of most of my patients. They don't have great lawyers that are representing them. We have to go to the, Hastings Law Center. I go for free legal aid wherever I can get it, but I'll tell you, by the time we get to it, a lot of things have already been put into motion that we have no control over. And so we have to just either muddle along, or I have to kind of take an initiative that's in a way being like their lawyer, unfortunately. Not a very effective one, I guess, but I have to try to figure out what the laws are and what their rights are and advocate from the clinical end. It's really important in terms of all of these decisions at the front end when somebody presents in a crisis that you evaluate their feelings about their current job, really evaluate well the workplace stressors and strengths and their desire to return to that particular job or employer. And you want to evaluate the likelihood that they'll be able to return within 3 months, because under the law, they have 6 months of short-term disability if they work for a year, but they only have 3 months to get their old job back. So you can keep them out for 6 months and they'll get state disability benefits, but they're not going to necessarily get their old job back. So that's an important consideration in thinking about the situation. All right, so assessment. Assessment is evaluate skills, strengths. This is a vocational piece now, not so much just the clinical, but evaluate their skills, strengths, preferences, and supports. Develop a plan with timeline and goals. Referrals, employment agencies, community college, supported education, all of those types of things. There are some kind of combined vocational research clinical programs like UCSF PART study that has a cognitive remediation study and can provide some things in terms of employment. NIMH used to have a supportive education program, and they're in very strange places, some academic settings, some government settings, and I don't have a great list of all of the really special programs. That would be a good thing to kind of put together. And as I noted before, I do a lot of supportive education work as well, so that's where you would be looking at the universities as opposed to Department of Rehabilitation or nonprofits that do vocational supports. Next slide. We missed a slide that was that I skipped because we were out of order. Assessment of people currently employed. Can we go back to that? Okay. There it is. Okay. Okay, no. Okay, so this is a clinical kind of piece that I was noting. You want to evaluate the person's safety. When somebody's having a crisis, that's the first thing that's my response. What's their safety? Are they at risk of hurting themselves, or are they at risk of suicide? What's going to happen? Do they have a family? If they're not functioning, is something going to happen to their children? If they're not performing, are they at risk for losing their job because they're not performing? So you want to evaluate their safety and their current functionality and what they're at risk for in terms of the consequences of possible disability. You want to look at the type and nature and the level of scope and care that you think they need. This obviously could mean they might need to be hospitalized. Review the implications of going out on medical leave with or without a hospitalization and the alternatives. Review the benefits they'll receive. You want to know, do they have health insurance? What happens is somebody goes out on medical leave, they may be forced to start COBRA. And they may be forced to start paying for an additional health benefit they can't afford while they're in recovery. And so you really want to look at their benefits package for treatment as well as for financial support. Same thing we talked about, we didn't talk about here, but one of the key issues for consumers getting work if they're on SSI was what was going to happen to their SSI benefit. How much was it going to go down? And part of what we would do is calculate. If you get this much money, your SSI benefit's going to go down by this much, and is it going to be worth it for you to work unless you're making a certain amount of money? So you really want to look at their benefits, and you also want to know if they're going to be able to support themselves. Are they going to lose their house? What's the consequences? You want to explore and enlist whatever family and community supports they have. For example, I do alternatives to hospitalization. I will have a family member fly out, a mother will come out and stay with her daughter for 3 weeks take care of her instead of putting her in the hospital as an alternative. I'll set up kind of a creative residential treatment program for someone if they have that amount of supports, and I can guarantee their safety, they're in treatment enough days a week, I know that they're adherent, and we have a really good structured care plan that kind of serves as almost a day program, but within a community setting. You want to look at the health and rehabilitative care that will be necessary to get them back to work. And there again, you want to be really creative. You want to figure out if somebody doesn't have a hospital benefit, how do you, or a day program benefit or partial, how do you create a facsimile of that with supports that they have? Explore the ways they might continue to function at work and effectively address their issues with reasonable accommodations. Review the risks and benefits of disclosure. And I brought today a website link that I will provide later on. We'll add all these things to my presentation. It'll be on the Peoples with Disabilities website. But what I did is I brought a link to a whole article, a discussion of disclosure written by consumers, and looking at the pros and cons of disclosure and kind of a decision tree of how to do that. So that's a big part, really helping somebody evaluate the risks and benefits. Now there's so much stigma that part of what my job is to separate the stigma, the internalized stigma that people feel about their mental illness from the real consequences of discrimination which do exist, and to help them figure out what's in their best interest as opposed to what feels bad just because of the environment that we're in. And develop a short-term plan, because all you really can develop is a short-term plan. You're kind of working week by week. The first stage of any care plan is supportive and keeping someone safe. That's the first. You can't worry about long-term initially. You have to get them set up safe, get them in effective treatment, set up structures, get their supports together, and then you worry about intermediate and longer term. Next. We did this. Oh, I want to go back to the work. Go back.
Are you using consumer and client interchangeably?
I am.
Okay, thank you. I just want to make sure.
I want to say something about this because I imply here that the workplace can be toxic and can sometimes contribute to or be the stressors that causes. The reality is that for a lot of mental health clients or consumers, going back to work is not stressful. In fact, it decreases their stress because they're so stressed out about not having any money and not having anything to do during the day that it actually is a decrease in stress for them. So I'm not saying that there's any typical work environment that in fact the history of mental health treatment has been protective, not rehabilitative, and that ultimately the whole orientation is changed from protecting consumers and keeping them away from stressors to the opposite, which is empowering them. Everyone has anxiety and everyone's going to have stressors at work. And the fact is you want to empower people to be able to tolerate them and to achieve competitive work if that's what they want to do. So I think that's really important, and to say that I didn't want to give the impression that I think that work is automatically going to be the increased stressor or not be tolerable for somebody with a disability. The other thing is that people can have symptoms and still be very effective at work. I was seeing a man with schizophrenia who was totally paranoid about his boss, but he was doing a great job and he'd been there for 5 years and it didn't interfere. He was able to manage them. They did not interfere with his work or his functioning. And he didn't even need a psychiatrist to help him with reality testing. He was managing it. So the idea that just because somebody is symptomatic they can't manage is totally incorrect. Let me say that I deal with the fact that implementation is so grossly inadequate and access to resources and supports to ultimately do the advocacy in addition to doing the clinical treatment for someone who's disabled is so unavailable or expensive that it becomes ineffective or irrelevant. And it's not that, I think that one of the things we're seeing here is that we have people who can take a handful of cases. If I were to tell you how many cases I've tried to get legal help for with my clients without success, probably 30, and have been totally ineffective. I go to the Hastings Law Clinic. I call legal aid for help whenever I can. Now, if you can give me some resources that ultimately are effective, I will use them.
Well, have you tried? Excuse me. I'm very sorry to interrupt, but out of respect for our speakers, we would like them to finish their presentations without interruption, if possible. In addition, to Dr. Cohen, we have one more presenter, so if we could possibly hold out kind of questions, and it's really a little bit out of the scope with respect to health insurance. We're talking about employment issues here, so if we could maybe hold that discussion for later, that'd be great. Thank you.
So I would appreciate any help. I do what I do though out of experience and because other avenues have not been available to people. And basically, and I just want to say that a lot of these are life-death situations where, it's not a question. People I can't do the workers' comp for them necessarily. And they don't have money or resources or a lawyer or a family member or anybody who can do this for them. Now, if you have an agency that will do all of the advocacy, paperwork, and get this through for someone and get them the legal representation they need, that's fabulous, and I want to hear about it. So this is more of the clinical piece that's involved in the treatment. I do what I call insight-oriented cognitive behavioral therapy. And that's because it's mostly cognitive behavioral therapy, but as issues of, say, trauma that Anita had brought up and really developmental issues may come up in the treatment, we'll address them. But the general approach is cognitive behavioral therapy. And the idea is that ultimately you only look at the past in terms of how it influences the present. And it's a very skills and skills-based type of approach and practical approach to helping people. And this is combined with what I call more supportive types of psychotherapy. And one of the things that you do, and this is related to vocational as much as related to other kind of life situations, and this would be identifying triggers and particular symptoms and behaviors that interfere with work, identifying and developing coping and self-care skills and strategies, help with problem solving around difficult situations and relationships, role playing and planning, medication and symptom management, which are obvious medical pieces, dual diagnosis approach. The standard of care is that we now integrate substance use and psychiatric treatment together. They're not separated into two separate categories with different concepts, and they both come under the recovery approach. We have new kind of approaches like harm reduction, motivational interviewing, which is very much strength and empowerment-based approaches. Medical management of coexisting comorbid medical or substance abuse problems. And clearly we work to collaborate. I work to collaborate with people's primary care providers or specialty providers. Then there's lifestyle approaches. Work with everything in terms of exercise, recreation. You look at spiritual supports. You look at how their lifestyle habits are, and you try to help create a structure to maximize those things. These are more of the vocational stuff: resume development, job search, interfacing with employers regarding reasonable accommodations, obtaining benefits information, clearing expectations, helping clients to obtain legal aid, public benefits, and additional supports, which are definitely part of this process, and working with the client's family and primary support system. Why do I do this? Well, these are 5 reasons why I do this, because clients want to address employment issues as part of their care plan. because employment is integral to the recovery process, because my practice is based on a mental health recovery model, because evidence shows that to be effective, vocational services need to be integrated with clinical care, and because they're very difficult to find in the community. And the summary and conclusion is that whether people are receiving clinical services in the private or public sector, it is really essential that vocational services be provided and that they be effectively integrated with clinical care and treatment.